Hi, everyone, and welcome to the second week of breakout sessions of the virtual Iowa Governor's Conference on Public Health. Welcome back to many of you, and welcome for the first time for those joining us for today's presentations. My name is Lena Tucker-Reinders, and I'm the Executive Director of Iowa Public Health Association. I'm grateful you've joined us today and hope you'll continue to meet with us here every day next week as we continue learning from our very own public health experts around the state and sharing lessons learned and learning from each other. As you know, we usually meet in person to share best practices in April, and while we do miss seeing everyone, we are grateful for the opportunity that this pivot has given us. And in fact, what I've learned from this is that we've had such a broader reach this year, and all of our presenters have been able to share their work with more people. And so there's always a silver lining, and this is it for us. We've regularly had over 100 people joining us on each webinar, and the webinars are being recorded and posted to YouTube after this session. So if you've missed any of them and want to go back, you're welcome to do that. Again, posted at the IPHA YouTube channel. IPHA is put on every year, or I'm sorry, the Governor's Conference is put on by IPHA and IEHA, which is the Iowa Environmental Health Association, along with other partners. IPHA and IEHA are the primary partners, and I do encourage you to join your local association. We are both nonprofit membership organizations representing the public health voice in Iowa, and it is our honor to be able to present these workshops to you and advocate on your behalf across the state, but we do rely on membership to do that. So again, I encourage you to join IPHA. Our mission is to unite and strengthen the voice for public health in Iowa, which is exactly what we are doing today. I also want to thank the sponsors and exhibitors of the Virtual Governors Conference. Their commitment to public health is paramount, especially in these times. The sponsors of the virtual conference are Aetna, Amera Group, Unity Point Health, and the University of Iowa College of Public Health. You'll find a list of virtual exhibitors in the Governor's Conference website that you can visit at iowapha.org. These are the people whose tables you would have visited had we been able to meet in person this year. You would have visited their table and learned about their great work. You can still do so by visiting the links provided here. They are ACES 360, Champs Software, Des Moines University, Healthy Hometown, Iowa Corn Growers Association, the IDPH Bureau of Chronic Disease Prevention and Management, and Midwestern Public Health Training Center. Before I introduce today's speakers, just a reminder that everyone is on mute, and the chat function is enabled for you to communicate with myself and the panelists. So far, we haven't had any problems with any Zoom bombers. We want to make sure that stays that way. Again, you can put your questions in the chat function. At the end of each presentation, I will relay those questions to our presenters, and we'll have a short time for Q&A after the presentations. We do have 3 today, and so the time for Q&A, unfortunately, will be a little bit limited, but please do put your questions in there, and I will share all the questions after the presentation with the presenters regardless. So for those of you seeking CEUs for today's presentations, the second presentation is eligible for CHES and dietetics credits. To receive those credits, please put your name and which credit you're seeking in the chat box, and then we will make sure we follow up with you after that. You will get a certificate of attendance for all the sessions that you attend. There's also an evaluation that you'll need to complete, and we will send out that link as well. So without further ado, let's get on to our first presentation. Today's first presenters are Sydney Tylke and Laureen Hendricks, and they will be sharing their work in diabetes self-management education. So Sydney, go ahead and turn on your camera, and let's start your presentation.
I'm sorry, I'm having a little trouble starting the video.
I'll get it started. You're good.
Thank you.
There we are.
Excellent. Well, good afternoon, everyone. Again, my name is Sydney Tylke, and in conjunction with Laureen Hendricks, I'll be presenting to you the barriers and facilitators to the success of diabetes self-management education programs. So a little bit about who we are. I am a research assistant at the National Resource Center for Family-Centered Practice at the University of Iowa. And with me is Lorraine Hendricks. She is the Diabetes Management Coordinator at the Iowa Department of Public Health. And a general overview of what I'll be going over today is explaining what diabetes self-management education programs are, the barriers and facilitators to diabetes self-management education programs, and solutions to these barriers and potential expansion of the facilitators. So to begin, DSME is an evidence-based lifestyle change program that promotes the knowledge, skills, and abilities necessary for diabetes self-care. DSME is meant to provide the foundations to help people with diabetes to navigate decisions related to their health and has been shown to improve health outcomes. The education is for people who have type 1, type 2, and gestational diabetes. Education is up to 10 hours with group and individual sessions. And typical education content includes how to check one's blood sugar levels correctly, learning how to prepare healthy meals, learning how to adhere to one's medication schedule, talking with healthcare providers about one's health, and dealing with negative emotions such as stress. As you can see here, there are over 100 DSME sites in over 80 cities in Iowa. Counties shaded in green show where at least one program or site is located. And in 2018, over 10,000 people had at least one encounter with an accredited or recognized DSME program. And I should make a note that DSME programs are typically found within hospitals, clinics, and pharmacists. So a little bit about insurance reimbursement. DSME programs must meet evidence-based standards to become either accredited or recognized by the Association of Diabetes Care and Education Specialists, also known as the ADCES, or the American Diabetes Association. The incentive of becoming either accredited or recognized is to receive reimbursement from Medicare and other private health insurance companies. The Iowa Department of Public Health also helps programs become state certified, and by becoming state certified, these programs can receive Medicaid reimbursement and other third-party reimbursement. The Iowa Department of Public Health helps these programs with the use of the Iowa Administrative Code 641-9, and most Iowa DSME programs are both recognized or accredited at the national level and are state certified. So talking more about the Iowa Department of Public Health relationship with DSME programs, through the CDC's Improving the Health of Americans Through Prevention and Management of Diabetes, Heart Disease, and Stroke grant, also known as 1815. This grant funds state and local health departments to support programs and activities to prevent or delay the onset of type 2 diabetes and to improve health outcomes for people diagnosed with diabetes. And through the collaboration of Iowa Department of Public Health, they help public and private organizations throughout Iowa to provide education material and education through training, help certify diabetes education programs, maintain involvement with diabetes care providers and educators, and promote and support community-based self-management programs for people with chronic diseases. So provider referrals are often required for patients looking to join a DSME class. Getting a referral from one's provider or practitioner, such as a nurse or a physician's assistant, can often mean an internal referral to a DSME class within the health organization one goes to, meaning that the same place one would go to visit a doctor, that program would also be within, again, that hospital or clinic. However, there are some DSME programs that are outside healthcare centers, and external referrals are perfectly acceptable to DSME programs, but there often has to be an agreement between the provider and the DSME program staff to receive these referrals. It is often important for DSME program staff to look over patient health history and current information, which is why it is important that providers or practitioners put in current health information about their patients within the electronic health record system to keep program staff up to date about their patients. This is also important information to pull from when seeking insurance reimbursement, since the billing department staff often need this information to report to insurance programs. Before you is an ideal pathway for a patient to join a DSME program. When a patient goes to a doctor's visit, they can take a blood glucose test that will reveal whether or not the patient has diabetes. with the diagnosis of either type 1, type 2, or gestational diabetes, their provider should refer them to a DSME program. And when the patient goes to this program, they ought to have referral paperwork, which often includes documentation of diabetes diagnosis and the written referral form from either the treating physician or their qualified practitioner. With this referral paperwork, a patient can then join a DSME program. Okay. Now that we have gone over DSME program structure, how and why DSME programs become either accredited or recognized, how people are typically referred to DSME programs, we are now going to move on to the barriers and facilitators to running a DSME program. So, in 2019, DSME program staff in the state of Iowa were asked to provide data in accordance with the Iowa Administrative Code about 2018 program operations. The purpose of the survey was to examine DSME program's operation and to provide patient demographics, and this survey took place over Qualtrics. In addition to this, interview data was collected in 2019, and DSME programs that received 1815 grant funding were invited to take part. And the purpose of these interviews were to learn more about day-to-day program operations. These interviews took place over the phone and over Zoom and were semi-structured in design. So some of the questions asked in both the survey and the interview. Survey topics included the number of patients and patient demographics that joined and completed DSME programs, the number of programs that were either accredited or recognized, the DSME class scheduling, how programs schedule their classes, and the barriers DSME program staff experienced in running these programs, and the barriers they perceived in their patients. Interview topics included the program staff members' roles, how patients were referred to their programs, typical class content, relationship with the Iowa Department of Public Health, and barriers DSME program staff experienced in running the program, and the barriers they perceived in their patients to joining or finishing the program. So a bit more about data collection. The DSME survey netted 101 individual surveys coming from 101 sites. Our response rate was typically around 89%, and the people who filled out the survey were program coordinators or their staff. For the interviews, 5 programs were interviewed in total. 9 people participate in the interview, and the response rate for taking part in the interview was approximately 83%. And again, the people who took part were diabetes educators working in DSME programs in Iowa who had received 1815 funding grants. So these are some of the general results about the barriers and facilitators DSME program staff experienced. Some general barriers including getting provider referrals to build a group or cohort of patients, and the barriers that DSME program staff saw within their patients and this was from both interviews and the surveys, was that patients experience barriers around finances, scheduling, and lack of education materials in different languages. But some facilitators that the DSME program staff saw included provider familiarity with the electronic health record system, DSME programs being able to offer flexible scheduling, strong relationships with providers to get referrals to build up patient cohorts or groups, and then as well as support from the Iowa Department of Public Health. So a bit more about the barriers identified by DSME program staff. When it came to building a patient group, the lack of agreements with healthcare centers can make it difficult to get referrals to build up that group. And some of the DSME program staff expressed through interviews that they often would have to build connections between providers and practitioners. So they would have to schedule a meeting and then meet with the providers who often have busy schedules to quickly bring them up to speed, if you will, about DSME programs and give them contact information about the programs, and then referral forms that the providers or practitioners could use to refer patients to the DSME programs. And then with the DSME classes themselves, again, patients who have financial barriers or scheduling barriers are less likely to join DSME classes. And the lack of education materials in languages other than English means that people whose first language is not English have a difficult time in learning the things they need to know about managing their health. Okay. As you can see here on the chart, only 2% of the survey takers indicated that they had a formal agreement with a healthcare organization to get referrals for patients to join their program, and only 20% of the survey takers indicated that they had an informal agreement to receive referrals from healthcare organizations. So this lack of agreement between healthcare organizations can make it a bit more difficult to build up patient cohorts through referrals. And again, as I talked about a bit before, in the interview data, it was expressed by DSME program staff that they have to build patient groups mainly through referrals. So they have to reach out to providers and practitioners for patient referrals. And again, this means taking the time and finding the time to educate providers and practitioners about the importance of DSME programs. And then when it comes to DSME program staff on the perceptions of patient barriers, about 20% of the survey takers indicated that they believed patients felt extremely challenged to overcome financial barriers. And these financial barriers can come in the form of having to pay for program classes out of pocket if their insurance weren't covering it, or having to pay the copay to attend classes. 50% of survey takers indicated that they believe the financial barriers were either very challenging or moderately challenging. And then when it came to scheduling barriers, again, because typically DSME programs in Iowa are operated Monday through Friday from 9 to 5 p.m. And if patients have to work first, second, or third shift, or have other responsibilities they need to take care of, they may not have the flexibility to join a DSME program. But there are some solutions to these barriers. Having more formal and informal agreements with healthcare facilities to receive more referrals to DSME programs means it could be a bit easier to build up patient cohorts. Additional training for medical staff to apply for billing reimbursement, so that way patients' financial barriers can be reduced. DSME programs were able to offer more hours and hire additional staff, so that way there could be more flexibility for patients with diabetes to join a DSME program, and the additional staff could help out with more patients. Receiving education materials in additional languages other than English means there could be more outreach to patients. And a current solution, given the current pandemic, is that Medicare has eased guidelines for telehealth, which could circumvent scheduling barriers DSME patients looking to join a DSME program would face, and they could reach patients within their homes. Thankfully, it's not all bad news, though. There are plenty of facilitators to DSME. Thankfully, the lack of familiarity with EHR is not quite as big as a barrier. Only 11% of the survey takers indicated that they found that providers' lack of familiarity with the EHR is either very challenging or moderately challenging. Again, having the EHR to stay up to date on patient information and their health history can help DSME program staff kind of tailor and tweak educational content to better help patients within DSME programs. And some additional facilitators identified by DSME staff include flexible program scheduling to allow patients to come and join and participate in classes. If they could have, some programs are able to start classes before 9 a.m. and after 5 p.m., giving patients the opportunity to join the classes. Having those strong relationships with healthcare facilities can ensure provider referrals. Program staff that can talk to providers and practitioners who are willing to listen and learn can help them, again, build that relationship and educate providers about the program, which could lead to providers and practitioners referring their patients to DSME programs. Then within the DSME class itself, support from the Iowa Department of Public Health, which can provide individual assistance, training opportunities, and funding opportunities, can help DSME programs sustain themselves. And then what was indicated through the interviews is that DSME program staff saw a lot of patients within the classes develop support networks with fellow patients, which can bolster commitment to finishing the program. And after they leave the program, they have a new support network of people who understand what it's like to live with diabetes, and they can help them, with joining group exercise, make meals together, and have someone to talk to when they're feeling stressful or scared. So by all means, let's keep expanding these facilitators by maintaining strong relationships and collaborations with healthcare facilities to keep receiving provider referrals to help people, continuing to educate providers about DSME programming. If there's a new DSME program in a county, meeting with providers, or if there's a new provider or practitioner within a healthcare system, meeting with that person, letting them know we have a DSME program in the county. If you have patients with diabetes, please refer them to us so we can help them. Continuing to educate program staff and healthcare staff about billing reimbursement, again, reducing that financial barrier as much as possible, and if possible, increasing available program times so that more patients are able to have the flexibility to join a DSME program and receive the education and assistance they need to manage their health. The Iowa Department of Public Health continuing to provide educational and training opportunities so that DSME programs can learn about new toolkits or educational opportunities for their patients. And then within the program itself, encouraging that internal cohort support to increase commitment to the program and connecting people with one another so they have someone or other people that know what's going on and can relate to them so that they can manage their health. I do need to address some limitations within this project. All the data presented comes from one source, which is the DSME program staff. We were unable to talk to providers or practitioners or to patients about DSME programs. The relatively small sample size for interviews, again, only 5 programs were talked to, and 9 program staff were able to offer information about DSME programs. And this is a snapshot of program operations in 2018 and 2019. So this is about work that was done, not what is currently happening. Pardon me. But here are some resources that you can use to learn more about DSME programs. Included are toolkits program staff can use to help run their programs, as well as some information for patients who are looking to learn how to manage their diabetes. If you would like additional information about DSME programs, please feel free to contact Lorraine Hendricks. Her email is on the slide, and the link on my subjective right is about the Iowa Department of Public Health DSME information webpage, which can provide additional information about DSME programs in the state of Iowa. And I'd like it to open the floor to questions.
Great, thank you so much, Sydney. Lots of great information there. Everyone feel welcome to ask your questions via either the chat or the Q&A functions at the bottom of your screen. I'll start off with just a couple here. You mentioned that you one of the limitations of the study was that you were only talking with staff. Do you anticipate, or will you be able to do a similar evaluation and talking with patients?
Given the evaluation, it's more looking at the program itself and how the DSME programs use CDC funds to run their program. So while it would be a great opportunity to talk to patients, the evaluation that I conduct is not really about patient level behavioral change, if that makes sense.
Mm-hmm. So is there other opportunities to get patient feedback, or how is program evaluation then incorporate patient participation?
That's a great question. Some of the DSME programs told me through interviews that they had their own satisfaction surveys, or they will rather regularly check in with patients, either individually or groups, and ask how's the class going? Do you need to learn? Are you looking for specific information, or is there a topic you want to cover? Those are the ways that DSME programs can learn from their patients about how the program is going and how they're experiencing the programs.
Great. A couple questions here on reimbursement, so I'm going to tie them together. Wondering if there's difficulties for insurance reimbursement based upon provider, whether that's an MD, a DO, nurse, pharmacist, or dietitian. And then kind of a tie to that is with the current situation, Medicaid approving telemedicine, do you anticipate that now that we've shown that we can do it, do you anticipate that to continue? And what might you expect to see in terms of outcomes if we are able to continue with telehealth?
I can address that. Telehealth has been in Iowa for a while, not as much as it probably is now as far as diabetes self-management education. CMS has sent much information about telehealth and reimbursement and coding in order to achieve that reimbursement for diabetes management programs, diabetes self-management programs. There is some difficulties. I'm looking at the chat too. I'm sorry, Lena, I might not be answering your question, but there are some relaxation of the rules as far as telehealth in regard to Medicare, quite a bit, as far as group classes versus individual classes. Medicare has encouraged group classes because of that group dynamic. It's really important, but has opened up the ability to provide telehealth one-on-one with, as Sydney mentioned, in patients' homes. And there are some qualifiers to do that, but they just have to indicate that it's related to COVID, or it could also be related to the individual's difficulties intellectually or physical difficulties. So ask your question again, I'm sorry.
No, I think you covered it well. It was just one of the other part of the question was just whether you have difficulties based upon profession or provider.
There are, especially with telehealth, there are issues related to nurses and pharmacists. Those have not been approved providers by Medicare, even in this COVID time, for the billing. So that is an issue, and I know at the national level, there are people that are advocating for those disciplines to be allowed to bill telehealth for DSME, but at this time that hasn't been achieved. So.
Right. Oh, always advocacy work to do. Yeah. And the last question here, and this is a good one, and is how does one become qualified as an educator?
Well, there is the Association of Diabetes Care and Education Specialists. They just changed their name from AADE, American Association of Diabetes Educators, has a credentialing process, and not all of the staff in a DSME are CDEs or C, whatever the new coding is, but many of them are, and it's just an advanced education and a credentialing that they can achieve, and it involves the number of hours that they have had patient contact, and of course education components too.
Great. And I assume people can follow up with either you or Sydney if they have more questions. So
certainly.
With that, thank you both. Thank you, Sydney, and for the presentation, Laureen, for helping out with the Q&A here. We're going to go ahead and switch presenters now. Next up, we have Katie Jones and Kelly Siddig. Katie is from IDPH, and Kelly is from the Iowa Cancer Consortium, and they will be giving us insight into the growing need of cancer survivors in Iowa.
Thank you very much. Let me share my screen here. Thanks for having us. So I'm Katie Jones. I'm with the Iowa Department of Public Health Comprehensive Cancer Control Program.
And hi, everybody. I'm Kelly Siddig. I am with the Iowa Cancer Consortium.
All right, so we're going to provide a brief overview of what we're going to talk about. We have probably too much information for half an hour, so we're going to go through these a little fast, but we will be sharing these slides, so please look. You can see our notes too, which has what we're going to be talking about, and then every slide is cited also, so you can click on the citations if you want more information. So we're going to go over demographic trends, survivorship issues, and we did add some COVID-19 information related to cancer survivorship. And then we'll also talk about primary care and public health roles in cancer survivorship and supportive programs available. So Kelly, take it away.
Yeah, you bet. So we're going to start by talking about what survivorship actually means. And there are different definitions depending on where you look. But for the purposes of this presentation, we're talking about survivorship starting at the time of cancer diagnosis, regardless of the outcome. So you may be familiar with the report that the Iowa Cancer Registry puts out every year, their Cancer in Iowa report, and they define a cancer survivor as anyone who is currently living with or previously had cancer. And similarly, the Iowa Cancer Plan, which is a state roadmap for cancer control priorities and goals that our organization puts out, defines a cancer survivor as anyone affected by cancer, including the individual diagnosed, family, friends, and even caregivers. So the definition can be broad, but for our purposes today, a cancer survivor really is anyone who has ever had cancer, regardless of the outcome or where they are in their journey. Survivorship covers physical, psychosocial, and economic issues. It's complicated, again, all the way from diagnosis to the end of life. Survivorship experiences are different depending on a person's unique experiences. So this can include folks having issues with accessing healthcare and follow-up, changes in frequency of cancer screening, late and long-term effects of treatment, wellness and support services that are available, subsequent cancers, and access to other services for folks. Go ahead, Katie. So I'd like you to picture 5 people that you know. Out of those 5, an estimated 2 will develop cancer at some point in their lifetime. And I don't think this is probably a surprise for anyone. I think if we were all to pause, we actually could think of at least 2, probably more, people in our lives or people that we know who have been affected by cancer. Everyone is impacted by cancer in some way, either directly as a survivor, a caretaker, or just by knowing someone who's had cancer. Go ahead, Katie. Thanks. At the Iowa Cancer Consortium and the Comprehensive Cancer Control Program at IDPH, we work on all parts of what we call the cancer control continuum, and quality of life and therefore cancer survivorship is one piece of that continuum. So the cancer control continuum includes prevention, early detection, treatment, and then we talk about quality of life. Again, survivorship would certainly be part of that. Health equity, additionally, kind of spans that whole continuum as well, and it's very important piece throughout the continuum, and we'll talk a little bit about how issues of equity can affect survivorship as well. So I mentioned the Iowa Cancer Plan, and I'll touch on that a little bit and how survivorship and quality of life play a role or are expressed in the Iowa Cancer Plan. So the consortium first, we're a partnership of more than 400 health professionals, public health professionals, nonprofit professionals, also cancer patients and survivors, caregivers, social workers, anyone who has a stake or an interest in cancer control here in Iowa. And one of the things that our big network of partners does is develops the Iowa Cancer Plan. We all, as Iowans, have a role in reducing the state's burden of cancer, and that's really what we're all working towards. So we have 5 priorities in the Iowa Cancer Plan, and they follow that same structure as the cancer control continuum that I mentioned. So prevention, screening, treatment, quality of life, and then also health equity is a priority identified in the Iowa Cancer Plan. There are also 15 goals within the plan, including goal number 13, which is to increase access to and awareness of quality of life services available to cancer patients during and after cancer treatment.
There's a slight lag sometimes when I push to advance the slides. Okay, so I'm going to talk a bit about cancer survivors in Iowa, and these slides are from the Iowa Cancer Registry report that Kelly mentioned, which is called Cancer in Iowa. And so I really recommend you check it out. The 2021 was just released earlier this year, and I realize the citation on this slide is for the 2019 one, but other slides have the 2020 link on there. There are approximately 150,000 cancer survivors living in Iowa right now, and this number continues to grow, especially since the number of Iowans that are age 65 or older is increasing, and we know age is a big risk factor for cancer, and more cancer survivors are living longer, which is good news, and that means that there's more cancer survivors. The Iowa Cancer Registry tracks more than 99% of cancer survivors living in Iowa that have been diagnosed since 1973. And the report really gives a great snapshot of cancer survivorship in Iowa. So you can see here, this is from the 2020 report. You can see the most common types of cancer that for female survivors and male survivors. Breast cancer is by far the #1 type of cancer that female survivors have had, and then prostate is the #1 for males. When you combine males and females, colorectal cancer is very common. Skin and melanoma is another very common one. And then this shows the map of Iowa and the number of cancer survivors by county. So you can see that the urban areas have more just because there's more people in general, but many of our rural counties also still have a lot of cancer survivors as well. Okay, one thing I think was interesting that was in the 2019 Cancer in Iowa report is comparing cancer to heart disease. Heart disease is traditionally thought of as the leading cause of death in the US and in Iowa, and you can see in heart disease there's been tremendous improvement in the mortality rate over the last few decades. In cancer, there has been some improvement, which is also very good, but it does mean that actually cancer is sort of neck and neck with heart disease for being the leading cause of death. And some people might not realize actually in Iowa, cancer was the leading cause of death for a few years. It's sort of, you can see in this more detailed graph, it's kind of going back and forth. So, but people are thinking that eventually cancer will become the leading cause of death in Iowa and in the US. As Kelly mentioned, health equity is extremely important as well. And so one of the things we are very concerned about are health disparities, especially in cancer. So these are just some examples from the National Cancer Institute. For breast cancer, African American women are nearly twice as likely as white women to be diagnosed with certain kinds of breast cancer, triple negative breast cancer, and they're much more likely than white women to die from breast cancer. I know in the US and in Iowa, African American women are actually less likely to be diagnosed with breast cancer overall, but more likely to die from it, which really doesn't make a lot of sense if you think about that. And the disparities have to do with access to healthcare, racism. We'll talk a little bit more about that. There's a lot of different reasons why these disparities exist. Kidney cancer, there are some disparities with that with American Indian and Alaska Native populations. And then American Indian, Alaska Natives, and Asian and Pacific Islanders are more likely to have liver cancer. Liver cancer is a type of cancer that's on the rise generally in Iowa and in the US. For prostate cancer, African American men are more than twice as likely to die from prostate cancer. A lot of this has to do with access to treatment, health insurance, those kind of things. Cervical cancer, women in rural areas are twice as likely to die from cervical cancer. So there are geographic disparities as well, and the rural-urban divide and potential disparities in that is something we're very concerned with as well. And then with multiple myeloma, African Americans are twice as likely as whites to be diagnosed with and die from multiple myeloma. So these are some of the risk factors that are associated with disparities, which I mentioned before. There are, for some specific instances, there are some genetic and biological factors. One example is with breast cancer. People who are born female are more likely to get breast cancer than people who are born male. But then also, that's not the only reason for disparity. So there's also healthcare access, like I mentioned, socioeconomic factors. We know if you're wealthier, you're more likely to get better health care, and you're less likely to die from some of these cancers. Chemical and physical exposures are also a factor, and then also diet. And diet is also influenced by where people live, and same with physical activity, the environment that they're around. So for geographic disparities, one of the things we did to look at those is we contracted with the Iowa Cancer Registry to create these maps. And you are encouraged, you can actually look at these. And I realize I don't think I put the link on this slide, so I apologize for that. But these are on the Iowa Cancer Registry website, and they are interactive by zip code. So this is just one of the many maps that we have. This shows late stage colorectal cancer risk probability. And we don't have enough time to get into the weeds of what this all means, but the general takeaway of this is that red is bad and blue is good. So with this, you can basically see that we do have areas of the state where late stage colorectal cancer risk is higher than other areas. And generally for this specific cancer, it's the southeast part of the state, and then somewhat in the north, sort of west and north central. Interestingly, it's not really the big urban areas. You can see Polk County, Lynn and Blackhawk are there. One thing I want to highlight too is that this shows geographic disparities, but racial or ethnic disparities can be sort of hidden within that, especially if there's smaller populations within some centers. So take that with a grain of salt, but I think this is really helpful for showing geographic disparities, and it's useful for us to identify where we want to focus some of our efforts on. So I really recommend you dive into those too and see what your zip code is. And there's a variety of different cancers that we've looked at there. We have incidence rate, late stage incidence, and then mortality. So this is showing late stage colorectal cancer incidence, which means people who have developed colorectal cancer and had it identified at a later stage when they're less likely to survive. If you have a colorectal cancer identified earlier, you're more likely to survive. I also just wanted to share that we get a lot of cancer survivorship data from the annual Iowa Behavioral Risk Factor Surveillance System Survey, BRFSS. Hopefully all of you are aware of it, but if you're not, I recommend you check it out. It is self-reported data, but one of the default questions that's always included is asking if you've had a cancer diagnosis. And because of that, even if we aren't able to pay for extra questions, which fortunately this year we are able to pay for some extra survivorship specific questions, but even if we're not able to do that, we are able to pull some cancer survivorship data because we can at least look at everyone who answered that standard question about if they've had a cancer diagnosis and find out more information like, how is their general health, what other, what's their socioeconomic situation and things like that, and other health histories. I just wanted to also say that social determinants of health ties into this as well, especially economic stability is a big factor in cancer survivorship. Employment, lots of cancer survivors worry if they will be able to keep their job while they're going through cancer treatment. Income, the expenses of cancer treatment, debt, having medical bills or medical debt, and what support systems do they have? Do they have to drive a long way? And then also the healthcare system, of course, healthcare coverage, provider availability, we'll talk a little bit more about that too. The linguistic and cultural competencies, if someone is an immigrant, are they able to navigate our healthcare system, especially if English isn't their first language, and then the quality of care as well. All right, so now we're gonna go into some survivorship issues. So first of all, in Iowa, we do have a physician shortage. We rank 42nd compared to the US states for active physicians per 100,000. So that's looking at, obviously California is going to have more physicians than us, but per capita, we do rank very low. And then with primary care, we rank 35th. So we're a little bit more in the middle, but still lower than the average. We also, one of the things we promote is cancer survivorship care plans. And these are a record of a cancer treatment and cancer history, and they include checkups or follow-ups that people need to have. So this is something we really want to ensure that cancer survivors are getting as appropriate and that their primary care providers are getting it as well. So that is one of the projects that we're looking at too. It may also list possible long-term effects for treatments. So this is something that's, a lot of cancer centers are already doing this in the state, but it's just something that we're continuing to focus on and look at. One topic that has been increasingly heard around cancer survivorship too is the topic of financial toxicity. So basically this is talking about, on top of the toxicity that may come from cancer treatments, there's this financial toxicity that can affect cancer survivorships. So this is just the cost of treatment. So this is a model, that a conceptual framework. And Kelly, you can dive more into it too. Sorry, I just realized this was your slide. So, and you are muted, Kelly. So feel free to dive more into this. We've had some speakers talk about this as well.
No, thanks, Katie. I think that's fine. I mean, you really can't talk about survivorship issues without talking about financial toxicity. And I think that that's probably a term that lots of folks are familiar with. I did put the link for this slide and also several of the previous slides in the chat box too. So if folks want to dig deeper into any of those, know that those links are there. I will also note, Katie mentioned earlier that we're going to talk a little bit about how things have changed because of coronavirus. And I think financial toxicity is going to be a really interesting and important survivorship issue to watch, especially deeply moving forward because of all the changes that the world has experienced. Go ahead, Katie. Okay, and so of course we also can't talk about cancer survivorship without talking about the social and emotional impacts that cancer patients and survivors experience. This is a list of some of those, which include fear of recurrence. So many survivors worry that cancer is going to come back at some point. So once they're through their treatment, they can't always feel rested assured that they're done. That always looms over them. Grief is a natural result of loss. Loss can include loss of health, loss of sex drive, fertility, physical independence. There's a lot of loss that can occur with a cancer experience. Depression is a common social and emotional result of cancer. It's estimated that 70% of cancer survivors experience depression at some point. Body image is an important factor to consider. So cancer survivors who, for example, have experienced amputations, disfigurement, or a major change in physical function may experience body image concerns. A cancer experience can also affect one's spirituality. Some folks experience survivor guilt. It can affect relationships, key relationships in one's lives. And then also work. Work is a really important consideration for folks who faced cancer as well. They often feel that they can no longer relate to their coworkers who haven't experienced cancer. Support groups and mental health treatment can often help with some of these experiences. And then in talking about cancer survivorship and cancer treatment, even in general, pediatric, adolescent, and young adult populations are worth mentioning specifically because they have special considerations in survivorship, including thinking about fertility. It's a group that's either hasn't gotten to the point in their life where they are thinking about starting a family, or they're just at that point where they might be thinking of starting a family, or they don't know if they'll ever want to start a family. But those decisions often have to be made quickly when they're faced with a cancer diagnosis. And so that's a big consideration for this population. Late and long-term effects are also very important to consider. What that means is that especially for younger populations, these folks are living longer after cancer treatment than they ever have before in history. And along with that, we're seeing some of these late effects of very strong treatment in their lives as they're able to live to be older adults. And so that population is really facing a lot of challenges as they get down the road after their treatment. Additionally, young adult and young folks who face cancer deal with financial and health insurance issues. Again, we talked about physical changes, and that's true for this population as well. Not only reentry to school, or to work, but often reentry to school as well can be very tough for young folks and their families. And again, they're facing follow-up care for life. This is something they're going to be dealing with for the rest of their lives. It can also be exhausting and very difficult to think about finding support and appropriate care for the rest of their lives.
one thing we wanted to mention too is that going through cancer treatment and surviving cancer can also be actually similar to post-traumatic stress disorder for some folks. There is cancer-related post-traumatic stress, which is a lot like PTSD, but not as severe. Patients can have a range of normal reactions just when they even hear the word cancer at their initial diagnosis. Some of these include repeated frightening thoughts, being distracted or overexcited, trouble sleeping, and feeling detached from oneself or reality. And I know that we're touching on some big issues and don't really have time to dive into these, but one thing I wanted to mention too is that healthcare providers can, just like any of us, be biased and have biases, and they can also have unconscious biases related to race, ethnicity, sex, sexual orientation, gender identity, socioeconomic status, and race. And this can impact their behaviors and judgments, and they can impact how they treat patients and their patients' outcomes. So one study showed that about 80% of healthcare providers had an implicit or unconscious bias against Black and or Latino or Latina Americans versus white Americans. And this is something that many of us have just unconsciously. Being aware of it is helpful, and then there are steps you can take to address it. One study that I found about bias specifically with cancer looked at white oncologists with African American patients and then with white patients. They showed that white oncologists who had higher implicit or unconscious racial bias had less reported involvement with African American patients in treatment decision. They spent less time with those patients. They had blind observers rating physician supportiveness, and they had lower rates of physician supportiveness, and they even just smiled less at the patient. So just imagine going through cancer and then having your provider, your oncologist, have this bias against you that they might not even be aware of, but it's still impacting how you are being treated. And cancer treatment is stressful enough, but to have your provider be less supportive, not involving you in the treatment decisions as much, not smiling at you as much, I mean, that's just going to make the situation even harder. So that's something that's really important to look at too. All right, now we're going to really quickly go through COVID-19 and cancer survivorship issues. So one thing that we know is that some types of cancer and cancer treatments can weaken a person's immune system, and it puts them at risk for any type of infection, including SARS-CoV-2, which is the virus that caused COVID-19. So a lot of people who go through cancer treatment or have certain cancers are at risk for any infection, but COVID-19 is definitely one that we are especially worried about since it is a novel virus. This is a graphic from the World Health Organization that shows some different diseases or pre-existing conditions, and cancer is listed as one of them. And the National Cancer Institute has a lot more information, and so does the American Cancer Society and the CDC. One thing we wanted to mention that people may not be aware of is that the American Cancer Society is recommending that no one go to a healthcare facility for routine cancer screening at this time. So it means if you're due for a cancer screening for breast cancer, colorectal, cervical, or lung cancer, you need to postpone your appointment for the near future. This is something that is on our radar. We are worried because cancer isn't waiting until COVID-19 is not as prevalent. People are still developing cancer, so we are very worried about this, but we understand why there is a pause right now. But we want to make sure that when it is safer for people to go back into the medical system, that it's done in such a way where we catch all the people who have missed their appointments. And this, Kelly, go ahead, sorry.
Thanks, Katie. So I want to share, I think if there are good things that have come out of this whole COVID-19 time period, it's that we're all finding ways to try and support each other. And I feel like we've really seen that at the Consortium. So our job is to keep people who have a stake or are working or advocating for cancer control in the state, keep them connected, help them find resources, help them build capacity to do their job, and again, to just work to reduce the burden of cancer together. So it's all about that collaborative nature. And we've really seen a lot of outpouring from folks, from organizations who are offering support across, again, that cancer control spectrum, but including survivorship support. And so I want to share just a way to take advantage or to tap into some of those resources that are coming through the consortium. We're trying to keep people updated and connected. So if you go to our website, and Katie, maybe you can type this into the chat box for me. It's www.canceriowa.org. If you sign up to receive our newsletter, you will receive all these emails. We're trying to email out weekly, collecting the opportunities not just for professionals and advocates to learn and build capacity right now, but for people who are dealing with a cancer diagnosis as well. So I'd encourage you to hop onto our website and sign up for our email. And then while you're on our website, Katie, if you would advance to the next slide for me. While you're on our website, we also have this form up where we're trying to get a feel for what the community needs are across the state related to COVID-19 and cancer. And so if you are, for example, at an organization and you're hearing, let's say you're at a cancer center and you're hearing that patients are not able to get transportation to get treatment for cancer right now, please feel free to share that with us. We're also taking information about what services and resources people have to offer, and we're going to try and continue to share those out and do some partner matchmaking where we're able to, just to keep everybody connected. And that is on our website as well.
I think we only have 4 minutes left, so I'm just going to speed read through these. I just wanted to plug that IDPH created an image that's based on a resource by the National Association of Chronic Disease Directors that talks about managing cancer during COVID-19. It also talks about other chronic diseases, so I encourage you to check that resource out, which is in the link to. And there are more resources coming out every day. GW Cancer Center sent an email out just this week with tips for coping with COVID-19 for cancer survivors and caregivers. I also really briefly wanted to mention that and just acknowledge that there are COVID-19 health disparities that we are seeing in the data that I was sharing. You can see here, this is from the 20th, but the percentage of Hispanic or Latinos and African Americans that have confirmed cases of COVID-19 is much higher than the rate for the state generally. And a lot of these same disparities that are impacting why there are higher rates with COVID-19, there's nothing biological about these disparities. It is all based on access to healthcare, socioeconomic factors like where people work. And so a lot of those same reasons for these disparities also impact cancer. So I just wanted to mention that really quickly. And then for primary care plays a really important role. This article is really good if you're interested in this. It talks about the role of primary care and their relationship with cancer care. And then I know I'm going through this way too fast, I apologize, but there are some barriers with primary care integration in cancer survivorship. The healthcare system can be a bit siloed in this regard. So this talks about some of the different barriers that exist. And then public health's role really is we try to look at not just survivors, not just the individuals, but also the whole socio-ecological model. And we're trying to accomplish those Healthy People 2020 objectives of increasing the mental and physical health of cancer survivors and the proportion of cancer survivors who are living 5 years or longer. And then we just wanted to really briefly shout out some support programs. Yeah, Kelly, go ahead with this one.
Sure. The American Cancer Society is great, not only right now, but all the time for cancer caregivers and cancer patients. Cancer.org is their web address. They have a chat line, a phone line. It's a really great place to find local resources.
We just wanted to plug that Quitline is still up and running and available, and that's something we also promote for cancer survivors too who are interested. Sometimes having a cancer diagnosis is a prompt for people to change some behaviors, and so Quitline is available. And then also physical activity and nutrition are really important, so we focus on that in some of our programming too. GW has a great e-learning series that's for primary care providers about cancer survivorship. So we really encourage primary care providers to go through that e-learning series, and you can get CMEs for that. There's also the CDC developed this Talk to Someone simulation, which is They developed this before COVID-19, but it is nice because you can talk to someone virtually. You chat with this woman, Lydia, who's a cancer survivor, and it's about staying healthy after a cancer diagnosis. So something that people can do in their homes. And then Kelly, you're muted.
Sorry, thank you.
That's okay.
Finally, I will just share some really cool projects that are happening across the state that have to do with cancer survivorship. So we offer grants that support the Iowa Cancer Plan, which we talked about before. And we have about four grants that have been funded that focus on survivorship. Katie, do you want to click over to the, yep, thank you. So Above and Beyond Cancer works to elevate the lives of people who are touched by cancer, and some of the work they're doing is expanding programs that focus on mindfulness, wellness, nutrition, physical activity. Next one, Katie. All of Me is a program that works with providers to learn how to talk to their patients about sexual health, which is a big and often not talked about issue for cancer survivors. Transportation is huge, and the American Cancer Society has been a wonderful partner working with cancer centers across the state to not only offer transportation to people who need cancer treatment, but also to look at some of the bigger systemic issues and develop some collaborative partnerships. And then finally, on a very different vein, we are supporting an organization called Living Proof Exhibit. They've put together an opera that takes the perspectives of multiple cancer patients, and they also offer art therapy to cancer survivors and caregivers throughout the year.
Well, thank you, Kelly and Katie, for your presentation. And I know we had to rush through, and there's so much great information available on the Consortium's website and IDPH. You actually answered most of the questions that came in. So kudos for being for your crystal ball, I guess. Just a reminder to everybody, the presentations are being recorded and they will be available on the IPHA YouTube channel. And I will be posting links to all the slides too. So if you missed any of those links, especially for the resources that Katie and Kelly were talking about, those will all be available on the slides. So thank you very much, both of you. Thank you for the great work you're doing and supporting not just cancer survivors, but all of us that are working on their behalf as well. And I look forward to the work that you'll be producing, I'm sure, looking at COVID-19 and as it relates to cancer in the future. So thanks again. And now we're going to switch to Ingrid. Ingrid Gronstal is with Iowa Environmental Council, and she's going to wrap up today's webinar with a look at Iowa's private wells and contamination concerns. So go ahead, Ingrid.
All right. Can you see my screen? Let's see.
Yes.
Okay. Hello, everyone, and thank you for having me today. I was, we were definitely disappointed that we didn't get to give this presentation in person, but obviously, there's a lot of circumstances right now happening that people did not expect. So I appreciate the opportunity to participate on this Zoom conference and just the opportunity to talk to all of you today about our work. So I'm Ingrid Gronstal Anderson. I'm the Water Program Director here at Iowa Environmental Council. My colleague Alicia Vasto also helped put this presentation together. I decided, since it was just a Zoom presentation, that I would just take the helm today, but I wanted to make sure she got credit for her work on this presentation and this project as well. So just a bit of a roadmap for this afternoon. I'm going to be talking about drinking water in Iowa and drinking water sources, where there are contaminants coming from primarily from agricultural pollution in the state, and how those get into drinking water in Iowa. And then I'm going to be focusing particularly on private wells and private well testing. This is an area that I think doesn't get as much attention broadly when we talk about drinking water sources, but there are, as I'll get to, a lot of Iowans who get their water from private wells, and maybe quite a bit less regulation and information about what is actually in that private well water. Our contaminants that we're looking at primarily today are nitrate and bacteria, and then we'll go over you know, the lack of testing in the state, the lack of a complete data set, and then what those, of the tests that have been done, what those tests show as far as contamination of nitrate and bacteria. Just a little bit background on the Iowa Environmental Council. We are celebrating our 25th year this year. We are a nonprofit, nonpartisan environmental law and policy advocacy organization. So we work primarily on clean water and clean energy across the state. We're based in Des Moines, but we are a statewide organization. We have about 80 member organizations. We have over 400 individual members, and then we have thousands of supporters across Iowa. So we're the largest environmental coalition in the state, and we take that responsibility seriously, and we try to be the voice for Iowans as far as environmental law and policy in the state. And these are just a few photos of the various different kinds of work. Is generally separated, or not separated, but we do education and outreach, we do legislative and policy advocacy, and then we do also have strategic litigation where necessary. I'm an attorney by training. We have 3 other attorneys on staff, and we have, you know, policy analysts and that sort of thing. So we're a science-based organization, but our bread and butter really is the law and policy aspects of our work. For this project specifically on private wells, we worked with the environmental working group. Like I said, we don't have scientists on staff, so they took the lead on the science and data gathering and analysis portion of this. EWG is also a nonprofit, nonpartisan organization. It's based in Minneapolis, or Minnesota. And they do a lot of really good science-based research on environmental health and environmental protection. So just quickly talking about where Iowans get their drinking water. 90% of Iowans get their drinking water from a public water supply. So this would be a municipal utility, or maybe a rural water utility. A lot of Iowans get their in central Iowa get their water from Des Moines Water Works, and all of these utilities are covered by the Safe Drinking Water Act, one of the sort of tentpole environmental laws that was passed in the 70s, along with the Clean Water Act and Clean Air Act. But that governs drinking water providers. So these utilities have pretty strict guidelines as far as what continuous monitoring, permit levels, discharge levels, testing to make sure that drinking water meets all of the regulations and requirements. One thing we are hearing across the state is that smaller utilities, particularly in small towns that may have a shrinking property tax base, are having a difficult time meeting those water quality standards. If you have to install hundreds of thousands of dollars of technological upgrades to your water plant, and that results in increases in rates for water for a small town in Iowa, obviously that's a concern, and that's a difficult position for those folks to be in, and that's something we talk about a lot. Again, when we talk about agricultural pollution, agricultural operations are not subject to the same types of permits or requirements or regulations. And so this is something where small towns in rural Iowa may be forced to basically bear the burden, the economic burden of dealing with that pollution coming from non-point sources across the state. So that's one sort of side note, public health and equity issue in rural communities with public water supplies. But that's not the main focus of what I'm discussing today. But another issue with rural drinking water supplies is that a lot of Iowans, and maybe a surprising amount for some of you, hundreds of thousands of Iowans get their water from private wells. And unlike these municipal utilities that are regulated under the Safe Drinking Water Act, private wells are not. So private wells are the water in those wells is required to be tested when those wells are installed, and then no other tests are required. So there's no regulatory enforcement or requirement to make sure people understand what's in their drinking water from private wells and make sure that that water is not contaminated. And the contaminants we were concerned with in this report, again, are primarily from agricultural sources in Iowa. And this makes sense when you think about just the amount of land in Iowa that is productive land. Based on research from Iowa State University, 92% of the nitrogen in Iowa's waterways comes from non-point sources. And when I say non-point sources, these are, again, terms of art in the Clean Water Act, but basically point sources, utility or an industrial plant or something that has, a pipe where you could test the water coming from that point. Non-point sources are things like agricultural operations or, fields or that sort of thing where you would have contaminants getting into water coming from that, but there's no one single point that you could test or point to as the source of that pollution. So in Iowa, 92% of that comes from non-point sources, the vast majority of which in Iowa are agricultural fields. In nitrogen, some of that is naturally occurring, but again, the majority of it comes from both commercial fertilizer and animal manure that's put on fields to help increase crop yields. The drinking water standard for nitrate is 10 milligrams per liter. That was based on a study done in the 1950s related to blue baby syndrome, and I'll get into that a little bit more later. But based on other research that's come out since the 50s, there's some indication that other negative health consequences may be at higher risk if you're drinking water that's as low as 5 milligrams per liter. Nitrates are also expensive to remove. So this was one of the main issues in the Des Moines Waterworks lawsuit a few years ago, that Des Moines was going to have to put in nitrate removal systems that would be passed on to ratepayers. This kind of goes back to what I was saying on the previous slide. But again, if you're talking about your own private well, if that's contaminated, the responsibility is entirely on you to remove that nitrate, and it can be difficult and expensive to remediate that contamination. Nitrogen in waterways can also cause harmful algae blooms, which relate to recreational waters. So again, not directly tied to drinking water or private wells, but this is another public health issue. If you have algae blooms that are creating microcystins or other toxins that can make people sick when they get in the water, those toxins can also make people sick if they are in drinking water sources. So again, all of these are connected to nitrogen and nitrate in the waterway, primarily from field runoff. We're also concerned about bacteria. That was the other contaminant of concern. And this bacteria, there's some occurring naturally. A lot of it also gets into waterways from manure fertilizer. And there's some connection here between livestock operations and bacterial pollution in private wells. Again, a lot of these private wells are in rural areas where you would have more livestock concentration and you would have more manure being spread. And so these correlations kind of all lead into each other. And per the EPA, when they test for bacteria, it's basically a binary. There's no safe level or safe standard. It's just a presence or absence of bacteria. So again, blue baby syndrome was one of the big concerns when these regulations were first written, but now there's pretty good evidence that there's an increased risk of various types of cancers, potentially birth effects as well. Bacteria like E. coli, obviously a lot of GI issues that can come from that, or other serious illness. And E. coli and other coliforms tend to be used as as indicator of other pathogens that may be present. So if you have E. coli, you may have other dangerous pathogens that could make you sick. So to this study specifically, it used DNR data of tests of private wells across the state from 2002 to 2017. So 55,000 of those wells were tested between that time period. And again, that's not a majority of the wells. If you go back to between 230 and 290,000, 100,000 wells across the state of Iowa. And a lot of this contamination was present in rural counties. So again, this is not a, urban versus rural issue. These are issues that are happening entirely in rural populations that are maybe also underserved or disadvantaged economically. So across all of these nitrate tests that were happening between 2002 and 2017, the average nitrate concentration was 4.39 milligrams per liter. So that's getting pretty close to that 5 milligrams per liter number that can be an indicator for negative health outcomes. And again, if that's the average, you have a pretty good number of that. That's half of that that's higher. That's above that 5 milligrams per liter number. And then these trends are showing upward amounts of nitrate. So nitrate concentrations are getting worse, not better, over time for this data set. Close to a quarter of all the nitrate tests were above that 5 milligrams per liter. So I guess not half. I mean, it's an average, not a median, but still a good percentage of that was above that 5 milligram per liter mark. That would be an indicator for increased cancer or birth defect risks. And 13% was above the 10 milligrams per liter. So that's above the drinking water standard that is set for the Safe Drinking Water Act. And these tests are also showing an upward trend over time. As far as bacteria, close to half, 41% of all wells tested had at least one test where bacteria were present, and 8%, close to 8%, so that's 4,300 wells had bacteria 100% of the time they were tested. So again, this is a pretty significant amount of, these are a lot of people who are drinking water that's contaminated with bacteria. A good percentage also had either coliforms or fecal coliforms, and that's an indicator of, that manure is a source of this contamination. Testing frequency is also an issue. So not only are we seeing of the wells tested, significant amounts of those wells are contaminated, but we're also seeing that there's just not enough testing being done. So 63% of these wells that were tested were only tested once for nitrate, and a similar amount were only tested once for bacteria in this 15-year time span. And this is kind of an interesting, when I started doing this work, my husband's parents live on an acreage just north of Story City, and they have a private well. That's their source of drinking water. And my husband said, "Oh, I'm sure that my parents get their well tested every year." And just several months ago, he said, "Well, actually, I talked to my dad, and they haven't had their well tested for 15 years. And so, I think part of the challenge with this is it's just something that you don't necessarily think about. If there's not a requirement or not a reminder, if the onus is on the private well owner to make sure their well gets tested and make sure they understand what's in their water. I mean, these folks have jobs, and they have grandkids and kids, and they have, any number of other things to remember to do. So it's easy to let 5, 10, 15 years go by. So it's not a placing blame or finger pointing, but this is something that really does affect people, and people can't just assume that their drinking water is fine and go on with their everyday. And if it's contaminated and they don't know it, that's pretty scary. So again, that was just sort of a personal connection to people who drink from private wells, who assume it's safe, but they don't have any confirmation of that. And then as far as annual testing, even though the DNR recommends annual testing, only 10 wells were tested annually for nitrate. So out of these 55,000 wells tested, only 10 were tested annually for nitrate and 12 for bacteria. So that's a pretty low number of wells that are being tested per the DNR recommendations. There is also a difference in counties. So well tests are primarily done by county public health officials through the Grants to Counties program, and some counties are obviously doing better than others. Some, these 8 counties tested very, very few wells, and bacteria testing has been increasing over time, but nitrate testing rates are staying pretty flat. So we're not seeing an increase in people realizing that they need to have their wells tested, or thinking this is something that they should pursue more stringently. Also, and this isn't a huge surprise, if you test more frequently, you tend to find more contamination. So this might be a situation where even if you're in an area that doesn't have a lot of testing showing contamination, it could just be because you're not testing. And if you test more, you're going to see probably higher amounts of contamination. So more frequently tested wells showed more frequent contamination issues. And again, this data set is not complete, partially because there's a lot of wells that are just not being tested at all. And there are some that are being tested, only a couple times over 15, 16 years. And so it's hard to really get a good sense of what those trends are, just because this is an incomplete data set. So we also see that some areas that do have a lot of contamination don't have a lot of testing. So this is also an area of concern. There were only 2 tests in Wayne County, but the average nitrate concentration was 59 micrograms per liter. And then if you go back to, that's only a data set of 2, it's small, but that number is very high when you think of 10 milligrams per liter is the drinking water standard, and probably 5 is closer to the more appropriate standard to be protective of health. So, there's definitely more testing that needs to be done. And this is concerning that, there's not a lot of testing done in areas where we are seeing really high numbers. So that's another area where we want more research and more testing to kind of see what's going on there. There's also a pretty significant environmental justice piece to this. So low income counties, they have fewer tests, less testing. They probably are more rural and therefore have more private wells and less ability for those individual well owners to actually mitigate their contamination. So you can see here, these yellow counties have few tests. Again, Wayne County only had 2 tests, but they were really high nitrate concentrations, and the median income is less than $45,000 a year. So these are vulnerable populations that are, have we don't know how much contamination there is, but indications are that the contamination is high and these people are at risk. There are measures you can take to mitigate contamination in wells. And again, the Grants to County program does have funding available for well testing, but one concern we have is there's not funding available for mitigation at this point. So you run the risk of going onto someone's property and saying, oh yeah, you are potentially being slowly poisoned by your private well, have a nice day. There's not additional resources. So that's something on the policy end that we are advocating for is more resources actually for mitigation of these wells and this contamination as well. There are mitigations, but they don't always guarantee cleaner water. They're fairly expensive, and they don't really get at the underlying issue, which is, again, that agricultural pollution. So these are affixed to the immediate well, but not affixed to the source of pollution or the potential for future contamination, because the underlying conditions haven't changed. Again, some of these treatment options can be fairly expensive and time consuming and just sort of a pain. and again, treatment options for bacteria. And I'm just going to kind of go past these in the interest of time, but you know, the real thrust of this is that you know, environmental justice, you know, this is a real concern for, like I was saying, people who are in lower income communities, rural communities. They may not have access or ability to get onto rural water, or have the resources to mitigate well pollution that is you know, more likely than not present in these places. So you know, I'll get to this on the next slide, but again, one of the main concerns here is what is the source of this pollution, and how can we maybe look at environmental regulations and pollution control differently, so that if you control pollution at the source, that will be protective of a lot of these private wells as well as public water supplies, to ensure, you know, a better likelihood of clean and safe drinking water for everyone. Again, that's the environmental justice issue. Everyone needs to drink water. Everyone needs to have safe, clean water, and that shouldn't be dependent on whether you can pay for your well to be mitigated, or whether you can pay to get onto a municipal water supply. So we'd like to have more tests. We'd like to have more funding and have you know, more counties required to test wells instead of being able to opt out, especially in some of those counties that are lower income and they have very low frequency of testing. You know, those communities, it seems like it's imperative that they understand what's in their drinking water. And then talking about source water protection, this is kind of where I was getting at with, you know, making sure we have, you know, maybe land use changes and different types of approaches to pollution control, so that we can address pollution at its source instead of just trying to address pollution once it gets into water supplies. And this includes funding out of the Water Quality Initiative for source water protection, conservation practices on the land that remove nitrate and bacteria. These are, you know, like wetlands, buffer strips, cover crops, lots of these, the same conservation practices that are found in the nutrient reduction strategy, for instance, watershed planning and understanding, you know, where pollution is occurring in watersheds and how it's getting to various drinking water sources, including private wells. And then, you know, really reducing over application of both commercial fertilizer and manure, so that there's fewer or less bacteria and nitrate getting into water supplies. And with that, I will open it up for questions. I think there's a couple of minutes.
Great. Thank you so much, Ingrid. Thanks for sharing this information, of course, and putting those action points on there. It's always great when we have action ideas to go along with issues and concerns. One of the questions that's come in is wondering if there's, in addition to some of the policy options that you put, a move to require well testing when somebody sells a property that has a well on it.
I know that's one of the policies that we have looked at, and I apologize, I don't remember for sure if that's a requirement. I think it's frequently something that's suggested or something that a potential buyer would want to know, but I don't know if that's required for land transfers. But that question is on the right track. That's something that should be part of a land purchase.
And then one of the other questions that's come in is, it's actually from somebody who has done some well testing in her career, and is wondering more about the correlation between well testing and when you have positive nitrate or chloroform positive wells, but yet you're not seeing any adverse health effects, or people aren't self-reporting any, and wondering what type of tracking there's going forward when we look at self-report health outcomes and well contamination, so we can draw some long-term health impact assessments on that.
Yeah, I mean, I think I don't have an answer to that question directly, but I think that's something we would like to see and kind of try to figure out. This is something we've struggled with also with, like I mentioned, harmful algae blooms and, you know, people getting sick from swimming in waterways, but it's been hard for us to try to get data on, you know, correlation between where we've seen a harmful algae bloom and, you know, reports of illness, because that's not something that is, you know, if people go to the doctor after they've, you know, been out on the lake all weekend and maybe they've been drinking or not eating the best food, and then you have like some symptoms that could be microcystin, they could be something else. You know, it's not something that's screened for necessarily with consistency. And I would say the same thing with private wells, is I don't know that we have a good data set from the public health perspective of health outcomes connected to contaminations in drinking water. I know that there has been some work done, say, for cancer clusters and looking at where there's high private well contamination, and then if there's been higher rates of cancer in those areas. But yeah, I think that's data we would like to see, but it's been hard to come by so far.
Right. And we just had another question pop up, or not really a question, but it was a suggestion that a simple question about where do you get your drinking water would be something good to include in kind of, I imagine, primary care evaluations and patient histories and such. So great suggestions here. We're going to have to wrap up. We're at time here. And so I want to thank Ingrid and our other presenters, Katie Jones and Lorene, Kelly and Sydney. Thank you all for sharing your expertise. Thank you all that are attended and sharing your questions. We all learn from each other and grow every day from all these presentations. And as a reminder, all these presentations are being recorded and will be posted on the IPHA YouTube channel. So if you want to go back and review anything, or you missed one of the day's presentations, you can find it there. The slide presentations will also be linked, so you can download the slides and have contact information for the presenters and follow up with them. So again, thank you everyone for attending. As I say every day, we may be social distancing, but we're still together. We're still a network, and we are colleagues dedicated to public health in Iowa. So I look forward to you joining us next week as we continue our series. Next week we have on Monday we have two presentations about looking for a proactive approach for reducing patient medication costs, and then a second one, effective partnerships, understanding what other sectors needs and how do we do it. So thank you for today, and we'll see you again next week. Have a wonderful weekend.